So good morning, everybody. I'm very pleased to be here. I'm very thankful for the invitation. In fact, I am replacing the head of the unit where I work, Françoise Dubois-Harbert, who is really the person who has led most of the work that I will present. It's a pleasure to be in Portugal because part of my family are still living in Brazil, but I understand a bit of Portuguese from Brazil, but this Portuguese is a bit more difficult for me. And sorry for my French accent when I speak English. I'm from the Italian part of Switzerland. I speak French, German, English, and a bit of Spanish, but so today it's in English. So I work at the Institute of Social and Preventive Medicine in Lausanne, and in fact we have a long-standing history of evaluation of prevention program because in Switzerland in '87, when the activity started from the Federal Office of Public Health against HIV/AIDS, they decided also from the beginning to have a global evaluation of all what was happening in Switzerland. So we have quite a long history of evaluation and trying to also develop surveillance tools, being behavioral surveillance or biological surveillance, or what we call now second generation surveillance, so combining behavior and biological data. Our group, in fact, was composed of many specialists. In our institute, we are four. So Françoise Dubois is the head of the unit. Brenda Spenter and André Jeanne are sociologists, and myself, I am a medical doctor, as it was said before. We also worked with, we are still working with Vivian Hope from the London School of Hygiene and Tropical Medicine. He's the one in charge of IV drug users. He's a specialist in this field. Jonathan Elford, who is the one in charge of, or the specialist in charge of MSM. France Lert, who is the specialist of person living with AIDS. Ellen Ward, more for sex workers and STI prevention. And Maria Our, more in the field of migrants. So you see it's a sort of quite big international team. And the funny thing is that we have the mandate in Switzerland, although Switzerland is not part of Europe. I mean, this is... And the two people we work with at ECDC on a very collaborative way is Marita van der Laar and Anastasia Faris. So to start the story of our work with ECDC, in fact, we have had a first contract in 2008, and during 2 years we did an analysis of the current state of art regarding behavioral surveillance. So each country received a rather long questionnaire, and we collated this information. I have sadly to say that Portugal has not replied to this wave, although we have had information after. But in this final analysis, Portugal was not included because we have not had information from your country. There was a broad and in-depth analysis of behavioral surveillance that was conducted, and we established a first set of behavioral indicators related to HIV and STI in EU countries. So it was a wide range of indicators who were used in many different countries with very different methods, and we tried to put all that together to make sense of it and try to find the smaller denominator of all what was carried out so far in Europe. So the analysis was carried out on the survey topics that were most frequently mentioned by countries. So in most countries, there was something on general population. In a lot of countries on IV drug users and on MSM, very few on sex workers, and the less countries were reporting of having indicators or data on migrants and other population. We made also proposals by the expert covering each of the specific population, and we have had an expert meeting in Montreux, it's close to Lausanne, in January 2009. Using the existing international agreed indicator, we came up with also, after discussion in the European MSM group, we came up with a list of indicators who were sort of the essential indicator, if you would like, to measure on a regular basis. Those indicators were separated in two categories, what we call the core common indicators. There are 6. I will show you them after. Those indicators are really the ones that need to be used in almost all population. So if we use this indicator in general population, it means when we do something on MSM or on sex workers, we have to find also this indicator in this study. And as you see, we also recommended that whenever it was possible, that all countries could or should use those indicators. And after, there were another list of secondary or population-specific indicators. Some were proposed for the use in several populations, others were very specific and may be used in only one or in few populations. These indicators are also proposed to be used in all countries, and for some topics there were clearly more research needed, typically in the field of migrants. There is not an agreed not agreed indicators in this field. Migrants is a very vague definition. In fact, you can be an illegal migrant, you can be a freshly arrived migrant, and so forth. So it's very complex. And also in the field of people living with AIDS, there are also not clear indicators now that are really strong enough to be recommended at European level. So the next step after this first mapping report, you can find this full report also on the website of ECDC. I will show you after the internet website. So from this mapping report, we went on having a second contract from ECDC to support the implementation of behavioral surveillance related to HIV and STI in Europe. And this is a framework contract from 2010 to 2013. And in this framework, we developed the first what we call a work package. So the first thing that, and I will show you after the link to the website, is what we have called a user-friendly toolkit. And I think this instrument, especially for those who are in the field either of research or people who are trying or working in the field, could be useful because it's structured by population at risk. So if you are interested in finding information about sex workers, everything in there, or on MSM. Licença telefónica, no, cancelaron. I don't need to call my mom today, so. So there's a technical guidance with respect to principle of behavioral surveillance, also second-generation surveillance and methodology. So there are links also to existing toolkits. What we have realized when we did the work is that there is a lot of information on the internet, but it's very difficult to find. I mean, you have to go in very different websites, and there is nowhere the sort of centralized information. It's what we did with this toolkit. There you can find all this information. In the toolkit, there are this set of indicators, and we have also taken account the international indicators, so the UNGAS, EMCDDA, Dublin Declaration indicators, and there's some recommendation for local implementation. So it looks like that. You will not see everything especially from the back of the room. But when you reach this page where you have this surveillance toolkit, you have a definition of what is behavioral surveillance, the methods, and the indicators. And if you move from the sort of entry page, for example, here you have the core indicators. You see on the right with a blue background the 6 core indicators that have been now agreed at European level. So it's the number of sexual partners in the last 12 months, use of condom at last intercourse. I mean, this is also one agreed. HIV testing, sex work having paid for sex in the last 12 months, what we have called contextual indicators, and a composite indicator of HIV knowledge. So those are the 6 core indicators that are supposed to be included in all surveys carried out in different populations. Now, if you move to the page, for example, on sex workers, there you have also the specific indicators for the sex worker population. If you carry out some study in sex workers, you see there is a list of indicators that can be on the right side, the specific population. So there you can click. This one was sex workers. So if you would like to have more information on injecting drug user, you just click there and you reach this page. And I will now show you in more detail what is the content of those pages, especially for MSM and for sex workers. So there are 2 main sources of information. One is the selected phase of available method for collecting behavioral data among MSM, for example. You see it's always the same structure. There is a design, or the type of studies that you could carry, the advantages, disadvantages, and the comments. And for example, if you look at internet survey, you see it's practical, it's a low cost, you can reach many individuals. there's an increased number of MSM who are using internet now, so these are the advantages. And after you have more details for these advantages and comments. So this is, and for each of those methodological approach, you have all the references which are linked to these methods. And the second page is on what we have called or selected as the best 3 methods to access MSM according to the context. And there we have divided this in 2. One is a situation in a country where you know that the population is quite well known, is quite easy to reach, and not severely stigmatized. And there you see, in this context, internet will be the first choice in terms of method. And also in a population or in a country, if I understood properly before, you talked about stigmatization in Portugal among MSM. So in this case, we still recommend that the first methods for surveys among MSM will be internet. Because the main indication for preferences is the fact that the marginalized group use internet, although they may not be willing to take part in a survey. So we know that the coverage of internet now is quite high in many countries. I am sure it's the case in Portugal. And the cost of conducting internet survey is extremely low. And especially if you would like to see trends over time, it's a very efficient method to collect information. There are a lot of issues about sampling and things like that. I mean, which are the website that you will put on the link to the questionnaire, things like that. But it's a very good method, and it's really what we have put as a first choice method for MSM in both situations. In your case, we have seen this morning the 2 surveys we have been done among MSM. It would be interesting to compare the results from those surveys with the EMIS survey that was carried out at the European level to see also what are the sort of differences in terms of prevalence and risk factors. For the sex workers, it's the same thing. You have also this big table here. I will not go through, but I mean the 4 type of design is what we call service-based. So sex workers who go to an STI clinic or to a hospital, or I mean this is what the service are offered in terms of treatment. The sex worker venue-based, or this is the place where the sex workers are doing their work. It could be the street, it could be in salons and things like that. And after you have the more sophisticated method that you have used, for example, in Portugal, but which are very expensive and very complex, the respondent-driven sampling, and finally you have internet. We are really thinking about, and this is again what we do recommend for those 2 categories of population in terms of the 3 best methods. You see, if we know well the situation and it is not, the population is not stigmatized, we do recommend the first method, the sex work venue-based, so the place where the sex workers are working. And in a population where the population is more stigmatized, this is more this approach of the service-based, so in STI clinic or in a clinic where the sex workers are going. Internet is probably the future also for sex workers, at least at European level. We are trying to put together a group to try to reflect on what could be the best strategy to develop an internet questionnaire for sex workers in Europe. I mean, the beauty of internet is that when you do the questionnaire in different languages, they're accessible in different languages. So typically in Europe, you have so many countries, but in Switzerland, we have sex workers coming from at least 30 or 40 different countries. So if you have this internet questionnaire for country, you can get already the translation done. So this is something that needs to be more researched and to see if it is probably one of the most efficient and also rather cheap method of doing surveys on sex workers. Along that, we have developed a self-assessment tool. So the idea was to help countries to make a baseline or to have an idea of where they stand in terms of behavioral surveillance system. We have piloted this tool in 2 countries, and we have finalized those tools in a meeting in June in Lausanne. We have also, from that, organized regional workshops, each time with 4 to 5 countries. So far, we have done 3 of those workshops, so 12 countries have participated in those workshops on assessing their behavioral surveillance system, and also trying to make the countries reflect on how far they can move on from biological and behavioral surveillance to what we call second-generation surveillance, so combining the information of the 2 systems. On top of that, apart from those workshops, we have also assessed the need for additional national support through a questionnaire, and we are planning to provide technical assistance to some country needs that have asked for that. So this self-assessment tool, which is also available on the website, the VCDC, contains one document that describes the 4 steps process. I will show you the process after, and one graphic aid, what we have called it the self-assessment worksheet. So this is some homework that people can do in their country. It's really going step by step. It's derived from a self-assessment tool that was used for the flu, in fact. I mean, the same logic, but for behavioral surveillance. And the key question that if someone is doing this assessment has to ask himself or herself, or the group has to ask, is the question of HIV is present in which most vulnerable groups. So we have seen obviously here in Portugal is mainly sex workers and MSM, it could be other groups. Does your system allow for the monitoring of HIV trends? We have already discussed a bit this morning that the 2 studies are not always comparable. I mean, this is the whole issue of surveillance. The whole issue of surveillance is having data which need not to be excellent, but at least data that can be repeated on a regular basis to assess trends. I mean, there are always biases. And people tend, when they think about surveillance, to do something which is too much research. I mean, surveillance, again, is something simple, but that needs to last on a long term. And in most countries, the problem is funding and sustainability, because people think about too complex systems. So the system must be really light, easy to access on a regular basis with very simple and agreed indicators. And what are the trends also? When you have information about cofactors, like typically if you see a change in the prevalence of syphilis or gonorrhea in your country, this is something which is very important in the surveillance system. This was the case even in Switzerland. We have seen an increase in the prevalence of syphilis since 5 years, and this was followed by an increase in HIV prevalence among MSM in Switzerland. So these are typically information that needs to be collected also. And again, this self-assessment tool is in 4 steps. I mean, first, to set up a self-assessment group that can be very formal or informal. We have seen that in many countries it was more sort of informal group at the beginning, because they need to convince the Ministry of Health of the importance of behavioral surveillance system. And after this informal group could be transformed in a very more formal group. And to conduct this rapid review and analysis of the available data. So what we have now, I mean, what are the data that can be used in Portugal typically? What are the biological data? What are all the studies that have been done among MSM and sex workers, for example? To put all those information together is something that is not so often done. Everybody is doing his work in his corner, but this coordination is not existing most of the time because there is no resources for that. And from this assessment work or this summary of what is existing to build a consensus on a new system or an improvement of the existing system. I mean, if there is already a system, it needs to be a resort on a regular basis every 2 or 3 years. If there is no formal behavioral surveillance system or combined system, you need to have a consensus on this new system, which is not always easy to find, but I mean, this is at least an important step. And finally, to formalize the system, to implement it, and to maintain the system, again, this is an issue of funds on a long run. So those countries, when they went back to their country after this 2 days workshop, they really moved on developing or reinforcing their system of surveillance. So it's not an easy task, but it could be very useful for the future. It's really, I guess, for Portugal to have a broad overview of what has been done in the field of surveillance for sex workers and MSM. I don't know if it was carried out. Again, I don't know because we have not received information from Portugal when we did the mapping report, but I think this is a step that is worth doing it. Because most of the time there is a lot of information, but it's not put together. And this secondary analysis also requires skills that need to be found also. And finally, these are the classical references that we have used to carry out this work. And again, on the website, you have, for each methods and for each specific population, at least 10 or 15 references which are up-to-dated, where you can get more information in case you would like to do that. Thanks for your attention.